and then go live. So, hello everyone. Welcome to another BrEDS webinar. Hopefully this is all working. And I'm very excited to introduce this topic tonight. So we've done about 15 or so, we thought, webinars so far on BrEDS since 2017, 2018. Over that time, BrEDS has grown a lot, which is brilliant. Like, we've got over 3,000 people who've actually signed up, like eating disorders professionals from the UK and beyond. And we're hopeful that people are finding it a very useful platform to connect with other clinicians, to share information and ideas, research projects, and everything related to eating disorders. So I'm John Roach. I'm a consultant psychiatrist who works on an adolescent inpatient eating disorders unit at Priory Altrincham in South Manchester. I also lecture at UCL. I've actually insisted that my students on the Masters of Eating Disorders watch this webinar so we can discuss it in our tutorial on Wednesday. So I'm kind of doing a bit of liaison between the UCL course and BrEDS. I used to work in ADHD, and I saw Sasha talking about ketogenic diets in neurodiversity and just nutrition in neurodiversity. And I was very pleased when she agreed to come and do this webinar for us. So we have Dr. Erin Bellamy, a metabolic psychiatry clinician and researcher who is recently completed a PhD in psychology, specialising in ketogenic diets and depression from the University of East London, and is soon to be a Chartered Psychologist. And we have Sasha Landskron, who's a registered dietitian with over 20 years of clinical experience working with children, teenagers, and adults in the NHS and private practice. And it's particularly interesting. I mean, I've always been very interested in ketogenic diets and ketosis and what effect that has on the brain. So, and Sam, do you want to introduce yourself?
All right, yeah, Sam Clarkstone. I'm the chair of BrEDS and the lead clinician for Gloucestershire All-Age Eating Disorder Service. And me and John will take questions from, if you put them in, write them in the comments, and we'll read them out for you, either as we go along, if they're put into a particular slide, or at the end.
Okay, great. So Sasha and Erin, take it away. And so usually 50 or so minutes of talk and then Q&A at the end. Okay.
All right, can you see the slides?
Yes.
Oh, great. Okay. Well, hello everyone, and good night. Good evening. Like John said, I'm Sasha and this is Erin. You can read a little bit more about us on our websites. We met clinically, and we have come together to make a company called Keto Med Academy because we're really passionate about getting information on the therapeutic uses of nutritional ketosis, both for mental health and for physical health. And I can say, from my own perspective, I've worked for over 2 decades in hospitals as a dietitian, and for the longest time, I avoided looking into nutritional ketosis because ketogenic diets, they seemed impractical and perhaps even unsafe. So I really understand that mindset because I was there myself until I saw the applications in clinical practice and started to read the research and to understand more about where we can use this. Now, Erin has got a fantastic base both in the clinical side and in the research side, and I would hazard a guess that there's probably not much that Erin doesn't know about ketogenic diets for mental health. So we've come together to join together to make this company, where what we're hoping to do is to get as many people trained up to understand how you can use these therapies in clinical practice. So an overview, we've got two sections. I'm going to do the first section and Erin will do the second section. I'm going to go through very briefly about eating disorder statistics, what we see in practice, the approaches, the treatments, and the results. We'll talk about the science and the background and the history of ketogenic metabolic therapy. And we'll talk about some of the current uses. We'll talk about safety and efficacy, and we'll do a quick recap at the end. Now, these statistics will be very familiar to you as you're working in or living in the eating disorders world. We know that about 750,000 people in the UK have got an eating disorder, and the vast majority of those are female. Atypical eating disorder is the most common, followed by binge eating disorder and bulimia. Anorexia nervosa is the least common, however, with the highest risk. There's lots more there about the age of onset and the prevalence, but again, these statistics are very familiar to us all. I think we'd all agree that in clinical practice, what we see is lots of cases that don't meet the classical criteria for eating disorders. And I was in clinical practice and did see patients back before the new diagnostic criteria, where we were, looking at the cessation of periods as part of the diagnostic criteria, and we know that a lot of people do have what's clinically significant, would be clinically significant as an eating disorder, and their periods continue. And I think that there's such a huge range in the spectrum of eating disorders and the crossover between sensory issues and ARFID and other eating difficulties. One of the things that's pretty evident is that there is a lack of eating disorder services across the UK in some areas, and the services that are available are often working at overcapacity. There was a tremendous increase in hospital admissions for eating disorders, so 48% increase during the pandemic, and that's based on a meta-analysis of 53 studies. And the thing that everybody talks about is that the rates are increasing with social media use and smartphone use. And the number that really sticks out in my mind is from back when I was working in a district general, and I started in that hospital in the Midlands in 2008. And in that year, in those 12 months, we had one inpatient ward and for pediatrics, and we had 8 admissions in 2008. And when I went off on maternity leave and came back, in 2015, we could have up to 8 eating disorder patients at a time on the ward. And so those numbers are, it's a real exponential increase in eating disorders. And that really sticks out in my mind, those numbers in particular. And I suppose there is a real strong correlation. In 2008, social media was not so important. Smartphones weren't so prevalent. They certainly weren't so prevalent. Teenagers were very unlikely to be having smartphones in 2008. But by 2015, there was a big change in all of that. And so I have seen that in my own practice. And it's something that, I think that we're all probably seeing as well. Okay. Slide. The approach to treatment. We take a biopsychosocial approach. We look at the causes that are biological, psychological, and social. And as a dietitian, what we do is nutritional. So we do a nutritional assessment. We look at replacing electrolytes and micronutrients, and the dietetic management, which is really key. And that includes meal planning, meal supervision, and then psychoeducation about nutrition. So reframing food and nutrition as being a positive, helping to teach our patients what's important, what they're getting from the nutrition. It's not just the calories. And I suppose another part of the management, which we hope to avoid, is NG or NJ feeding. A big part of what we need to consider is the prevention and treatment of refeeding syndrome. Now, interestingly, you can help to manage this or prevent it by limiting the raise in insulin that happens after a meal. And so some of the guidance that we use in pediatrics is to limit carbohydrate to no more than 60% of total energy, and that can help to prevent refeeding syndrome. However, when you really look into the guidance, for example, the Aspen guidance from 2020 on refeeding, they generally tend to not only increase how to increase the calories, but not necessarily the carbohydrates to prevent refeeding. And I think it's an important issue that probably needs a little bit more attention, because refeeding syndrome is driven by insulin. And that's where you have the problems with electrolyte imbalances and the risk. So let's talk about this particular food. And if you had a patient who had been starved, take a look at this ingredient list. We've got water, got maltodextrin, which is a sugar, hydrolyzed cornstarch, again, highly high GI carbohydrate, milk protein, sucrose, which is of course sugar, vegetable oils, not particularly great ones, some minerals, some stabilizers, E numbers, emulsifiers, which are not great for the microbiome, soy lecithin is the emulsifier, some flavorings, some vitamins, and to top it all off, an E number color that is known to cause hyperactivity in children. So is anybody surprised that this is the ingredient list for Ensure Plus, which is just one of the many types and brands of oral nutrition supplementation that we use to help support our eating disorder patients? And I wonder if it's the best option. It's certainly the cheapest option. A lot of times in hospitals, these bottles cost about 1 pence. And of course, Ensure is not the only brand that we use in hospital. There are many other brands available for use. But if you really looked at what it was made of, would you choose to refeed a patient with this product? It's just a question. I wonder if it draws up any thoughts or comments. So treatment results. We know that anorexia has got the highest mortality rate for any mental health condition. And about 20% of those deaths are due to suicide. The relapse rates are high. And in Canada, where I originally hail from, anorexia is soon going to qualify for what's called MAID, or medical assistance in dying. And there's a link there, number 5, to a really poignant video, that's an article that talks about a 74-year-old woman with anorexia who is going to choose this option when it's available for her, because she, as she says in her own words, "I'm done." And she can't see a way out. The mortality rate for bulimia is slightly better than for anorexia. And we know with binge eating disorder and the associated obesity, or even morbid obesity, holds with it a host of metabolic problems. But what is a ketogenic diet? Now, in research, it's really anything that's under 20 grams of carbohydrates a day. It's a low carbohydrate diet. So some people need to keep their carbohydrate under 20 grams a day. It's moderate in protein. We look at about 1 gram per kilo to preserve lean body mass, and it's high in fat. High in fat. 75 to 80% of the calories come from fat. And you'll also hear about ketogenic ratios. Certain ratios are predicted to be more effective than others for certain conditions. We usually start at around a 2-to-1 ratio, particularly with mental health conditions. And what that means is that for every that there's 2 grams of fat for every gram of carbs and protein combined. So if you've got 50 grams, it's 25. Let me work out those numbers. So if you've got 10 grams of carbs and 40 grams of protein, then you need 100 grams of fat to make that a 2-to-1 ratio. Oh, and why this works is how it works is when you restrict carbohydrate, that lowers your circulating insulin levels, and that encourages the metabolism of fat, which produces ketone molecules in the liver. And you might hear people talking about this metabolic switch that happens. And so when we don't have glucose to use, we can utilize the ketones for energy. And what happens is that the blood glucose levels regulate, and they reduce and they regulate to about 4 millimoles per liter. And ketones and fat provide this alternative energy source to the body and to the brain. And the real magic is that ketones have got this additional benefit. So they're neuroprotective. That's one of the reasons that they're used in cognitive decline and even in Alzheimer's. They have an anti-inflammatory effect, and they also have an anxiolytic effect, which for me was something, when I started out working with ketogenic diets, it wasn't in mental health. And it was actually for aesthetic purposes. People were coming to see me for help with weight loss or improved skin. And we were using nutritional ketosis for those purposes. But what really blew me away is they would come back for their reviews. They'd come back to clinic and they were calm. There was less speech pressure. People just seemed serene. And this was before I knew about any of the research and the clinical practice around nutritional ketosis. It was very evident to see. And it's quite an interesting aspect of the diet. When people get into ketosis, they seem to have this kind of serenity that comes in, and it is because the ketones themselves are anxiolytic. Here's a very clever looking slide that just shows what's happening. So as you drop your carbohydrates, the fat's metabolized and ketones are produced, which then enter the mitochondria and produce ATP or energy. Well, what's the history? Fasting as a therapeutic intervention actually dates back to the time of Hippocrates. And ketogenic diets have been used for over 100 years in pediatric epilepsy. So we've got actually a lot of clinical research and understanding in how it works in children. And what ketogenic metabolic therapy, or KMT, is it's a fasting mimicking diet. And essentially, this is how nature intended. We store fat in times of plenty, and it's a portable energy source. So it's not a coincidence. We don't store it in our arms and legs. We store it in an ergonomic place in our sort of abdomen and hips and thighs, because we are literally our own portable refrigerator that we can use in times of famine. Now, of course, in modern society, in many parts of the world, we don't have to suffer through famine anymore, and we have just times of plenty. But what happens is, with both fasting and being in ketosis, you produce these ketones because the fat's being burned for energy, as nature intended, to get us through the famine. We have lots of history as humans for using fasting and using keto diets, but they did fall out of fashion because new medicines were developed, medical advances were made, but now people are looking for holistic interventions for these complex chronic conditions, and so both fasting and keto diets have made a resurgence. As I mentioned, it's been used for 100 years in treatment-resistant epilepsy. There's an abundance of literature and evidence on research on the mechanisms of this diet. So it's currently being used for epilepsy. It's being used for metabolic syndrome and the related conditions like type 2 diabetes, PCOS, non-alcoholic fatty liver disease, obesity, hypertension, inflammation. It's used for fat loss and specifically for the reduction of triglycerides. When you think about cholesterol, HDL, LDL, triglycerides are like the good, the bad, and the ugly. Triglycerides are the really nasty ones that we want to reduce to protect our heart. It's being used in cognition and memory and in some forms of cancer interventions. Now, the emerging research is specifically to neurological conditions like Alzheimer's disease and Parkinson's disease and ALS. In the various eating disorders, it has been shown to be helpful with alcoholism and food addiction. It's also starting to be used in fertility to help with IVF success and in complex mental health conditions, particularly bipolar disorder. And you know, it's interesting that a lot of these complex mental health conditions use the same types of medications that are used in epilepsy. What about the keto flu? You've probably heard about this keto flu, and it is really how it sounds. It's a flu-like symptoms. So headache, lethargy, fatigue. Some people describe a bit of dizziness, change in bowel habits, constipation, sometimes leg cramps, sometimes bad breath, loss of energy, and it's essentially dehydration. So when you drop your carbs and your circulating insulin levels drop, this is a signal to the kidneys to excrete water and sodium, potassium, magnesium. And when our hydration levels and our electrolyte levels fall, we can get the sort of effects of keto flu. It can be managed, it can be controlled, it can even be avoided with the gradual initiation of a ketogenic diet, and particularly the correct supplementation. So making sure that people not only have enough fluids, but they have enough electrolytes and the right type and the right doses. Keto flu is generally temporary, and it has in part to do with the switch from the use of sugar as a substrate energy source to the use of ketones. And sometimes because more ATP is being produced when people are in ketosis, it can lead to some disruption of sleep, but that's also easily managed. Safety and efficacy. It is well tolerated by most. There isn't a risk of ketoacidosis except for those people with diabetes who are on SGLT2 inhibitors, or there are some case reports for metabolic acidosis when people are in ketosis and breastfeeding. There are some people who need to avoid it. Absolutely. There are some rare metabolic conditions that people usually are diagnosed within a few days of birth. They need to avoid being in ketosis if people have pancreatitis, if they're pregnant or breastfeeding, and generally acute eating disorders, they're to be avoided. The keto diets are to be avoided. Now, Erin's going to present some information about the use of keto diets specifically in eating disorders and even in acute eating disorders. So it may be that one day acute eating disorders aren't a hard stop for using KMT, but at the moment they are. Now, long-term or big side effects, they're really only present when you're using a really, really restrictive high-fat ratio. So you remember the 2-to-1 ratio is what we generally start with. 4-to-1 ratio is where there's 4 grams of fat for every 1 gram of protein and carbohydrates. So it's a very, very, very high fat, very, very low protein and very low carbohydrate diet. It's not nutritionally complete, but in some children with epilepsy, you need those ratios to prevent seizures. But we generally don't use those types of ratios in mental health. The key thing is for the diet to be well formulated with plenty of fluids, electrolytes, fiber, high quality processed foods. This is not about eating bacon and packaged fat balls all day. This is about eating whole foods and as many low carb vegetables as we can fit in. And it just so happens, though, that those whole foods are higher in natural fats. And if you do it correctly and you make sure that the fluids and the electrolytes are right, people aren't going to struggle with problematic side effects. A recap of section 1, talked about the statistics, approaches and treatment from a nutritional perspective, what the results are so far, what we see in practice. and then specifically to ketogenic metabolic therapy, the history, science background, how we use it, and its safety and efficacy. There's a few references there if you'd like a little bit more information, and then I will pass things over to Erin.
Thank you, Sasha. Hi, everyone. I'm wondering, John and Sam, if we have any questions coming through at this time for Sasha's section, and if so, maybe just jump ahead and let me know, and we could maybe cover some of those before I start the next section.
Yeah, well, Sarah Fuller, who's a dietitian, has asked, I wonder if the 2-to-1 ratio calming effect would be seen in those who are highly distressed with NGT feeds, referring to people with anorexia.
Sorry, could you say that again?
So Sarah Fuller wonders if the 2-to-1 ratio calming effect would be seen in those who are highly distressed with NGT feeds. So people with anorexia nervosa being NGT fed.
Yeah, it doesn't really matter, I suppose, how somebody is being fed. If you get the ratio right and you have somebody in ketosis, there is expected to be a calming effect. It just so happens that the NG feeds, they tend to be ultra processed foods, but you can get the ratios right. And in some ways, in lots of ways, it's easier to do it when I would imagine with an NG feed than it is with whole foods.
Okay, and then Ruth Dawson says, for those being tube fed, could the feed be made up to be ketogenic in theory? I know this would need the companies who produce them to do this, to then transition the patient to a ketogenic oral diet. The calming effect would presumably aid the transition from feeding under restraint and then from tube feeding to oral nutrition. That's referencing Sarah's question as well.
Yeah, so there are ketogenic tube feed products available.
Thank you.
So, yeah, if anybody wants to get in touch afterwards to speak more specifically or directly about any of those products, please do get in touch, because Sasha's got a lot of experience on that and she'll be able to direct you or point you in the right direction.
Mm-hmm. It's yeah.
No, go on, Sasha.
Yeah, it's generally it's VitaFlow that produces the products that are used in tube feeding for ketogenic diets. There may be some other companies available in other countries as well that produce feeds. And then I suppose we're not really using blended diets in hospital very much, but there's the option of producing ketogenic diets from blended feeds as well.
Great. All right, welcome to section 2. I'm hoping that section 1 gave you everything you need to know about the ketogenic diet. If you weren't yet familiar with it, you probably have a lot of questions and maybe you're still kind of wondering how and if this can work for eating disorders. So here's a little bit of an overview as to what we're going to cover. Going to have a discussion about the considerations, maybe around some of the arguments that people might have against this approach. Going to look at KMT and eating disorder research, the eating disorder research with the strongest evidence. We'll have a look at some of the biological mechanisms of eating disorders and ketones. And then thinking more practically, how could it work in practice? Who could it work for in practice? Thinking maybe more so about the personalized biopsychosocial approach, and then a little bit of a recap. Okay, considerations. I think we need to get this one out of the way early on. So I think, anybody who's working in eating disorders research or in the eating disorder world, dietary restraint theory comes up a lot. And there's this whole idea about, if you restrict certain foods or if you restrict a certain amount of calories, it will then cause you to compensatorily eat. So restriction causes that eating. There has been a lot of research as far back as the 1970s when this theory was when it came about. And initially, the theory came from some old starvation experiments during war times. And it was thought that a calorie restriction approach would then cause people to overeat once food was available again, which in theory makes sense. However, when you unpick that theory and you look at the data more closely, it was less so about the calorie restriction and more so about the fact that the people were, or the participants were eating foods that were not nutritionally complete, that were void of vitamins and minerals and amino acids. And so therefore there raises a question about, you know, is it more so the malnutrition and less so purely just the calorie restriction? Some randomized control trials, which are our gold standard in science, looked at this more closely in 2008 in 2 studies funded by the National Institute of Health. And actually they found that calorie restriction, so restricting the calories or even the intent to restrict calories, does not cause eating disorder symptoms and does not cause eating disorders. However, there may be a couple or a small percentage of people that may be vulnerable to eating disorders. And this is specifically, as I mentioned, maybe those who are malnourished, those who are overly stressed, or those who may have a phenotype, so a gene and environment interaction, or an overlap with certain affective disorders like OCD or some other affective disorders like bipolar disorder. Right now, there is a current call to review the dietary restraint theory. So I know some of you are probably thinking that, you know, restriction, ketogenic diets might go hand in hand, and therefore it might not be an approach to take with people. However, I would encourage you to stay open-minded as we look through this research. And there is a current call right now from the research societies to review this theory. Coming into refeeding safety. So Sasha touched on refeeding earlier on. I know some of you mentioned NG tube feeding. I'm not sure how many of you work with people who are being tube fed. If we're thinking about refeeding onto a ketogenic diet, if we're thinking about carbohydrates versus fat, carbohydrates will increase the insulin spike. If we're moving into fat and protein, we're going to have less insulin spikes, therefore less electrolyte imbalances, more hydration, less risk of dehydration. So it's, in theory, though it hasn't been tested, we would think that it would be a safer approach to refeeding onto KMT than it would be the standard approaches. But it hasn't been tested in the research yet. When it comes to sweeteners, I think the jury is still out. Now, lots of people have lots of opinions about sweeteners and whether people should use them and whether they shouldn't. With non-nutritive sweeteners, the research is still quite unclear, but what we do know is that it can upset the gut microbiome, and in eating disorders, that's a big deal. In practice, what I say to people, so I work with people with eating disorders as well as affective disorders and other mental health conditions. I say to use as a crutch for a short period of time, but with the aim to come off them completely as soon as they can. So if they need them for a couple of months, fine, but the goal is to come off them completely. Okay, ketogenic metabolic therapy and eating disorder research. So the focus is on eating disorders with the most research, which right now is anorexia nervosa and binge eating disorder. If we think about pharmacology responses, anorexia nervosa doesn't really have a great response to pharmacology. Okay, but bulimia nervosa does, as does binge eating disorder. So though there isn't any research right now coming through on bulimia nervosa and ketogenic metabolic therapy, it does respond well to pharmacology, just like binge eating disorder. So we're seeing some research come through now. It's in peer review. It'll be coming through shortly. And I'm hopeful that we will see the same impact of KMT on bulimia nervosa too. I think the most important thing here is probably the wording of ketogenic metabolic therapy. Most of you know ketogenic diet as a diet, and you have seen in the media ketogenic diet this, ketogenic diet that. There are many ways, as Sasha has mentioned, there are many ways to do a ketogenic diet. This is a ketogenic diet as a therapeutic recovery model. So this is not the bacon and, you know, the fat balls that Sasha was talking about. It's not that. This is a well-formulated ketogenic diet used as a therapeutic recovery model. That's what we're looking at here, and that's what we will see in this research. Okay, so I'm going to go through a couple of anorexia studies and a couple of binge eating disorder studies, and these are in chronological order. So if we go back to 2020, which is not long ago at all, there was the first case study that came through. Now you can see here on the left, this is a vignette from the case study. Her name is Caroline. I can actually find her on YouTube. You can hear all about her story. She says, I now consider myself to have a sugar allergy. When I eat avocados or bacon and eggs, the voice, the anorexic voice, is softer. If I eat sugar, I feel euphoric, but the euphoria has feelings of panic. So there you can see she's alluding to that sense of calm that she gets when she is in ketosis. So this is the name of paper. So remission from chronic anorexia nervosa with ketogenic diet and ketamine. So this lady, Caroline's 29 years old with anorexia and major depressive disorder since she was 14, I think. Yeah. BMI of 16, that was the lowest she got to. She started ketogenic metabolic therapy at a BMI of 21. She had a patient health questionnaire 9 of 13. So the PHQ-9, it measures depressive symptoms. And so it ranges all the way up to 20. A score of 13 initiates or shows that there's moderate severity of depressive symptoms. She started a ketogenic diet, so eating 3 meals a day. She supplemented with carnitine because she was deficient. She also supplemented a multivitamin. She did that initially for a month, and then following that, she took 2 weeks of ketamine infusions. So at 8 weeks, so just 2 months, 30 to 40% improvement of that anorexia, on that anorexic voice. Her PHQ-9 reduced to 2, which, if you're familiar with the depression scale, it means she doesn't have depression anymore. Her BMI restored at 3 months, so only 12 weeks of this, and her BMI was restored, and she was continuing the ketogenic metabolic therapy. What we don't know, however, from this case study is if it was the ketogenic diet, if it was the ketamine, or if it was a combination of both. We do know that she saw huge results or huge improvements from the ketogenic diet initially, but it didn't get her the whole way, and then the ketamine, improved further. But was it a combination? We don't know. So further research is needed here. You can find Caroline Beckwith on YouTube, and I encourage you to go and listen to her story. Next up, 2 years later, pilot study. So again, if you have a look on the left here, I only ate such a ridiculously limited amount of food that the logistics of switching to keto were not that hard. When you think you want X, have Y instead. If you have 3 X's and that's it, then have 3 Y's. And for me, the ketos were bacon, eggs, cheese, avocado, and MCT oil. So I added these vignettes because I want you to understand what it's like from the people doing it from their perspective, because I can sit here and tell you all about the research, but you need to see how it can work in practice and what people are saying. How does it work for them? Let's have a look at the pilot study. So 5 adults, weight recovered anorexia, so BMI of 17.5 or above. They all had comorbidities. This is common, okay? So general anxiety disorder, PTSD, major depression, OCD, and panic disorder. Though they were weight recovered, they still suffered with ongoing anorexic thoughts, behaviors, and that voice. So the weight was restored, but they still had that voice every day, and still had the guilt and still had those feelings. They followed KMT for 8 weeks, so 2 months, followed by 6 ketamine infusions. They did this for 1 year. Over 6 months, they saw improvements using the eating disorder examination questionnaire. This then has generated new study coming up shortly with more rigor. And if any of you are familiar with the Bazooki group, they will be funding this research, and it's great that they are, because more research is needed in this area. So this pilot study, very positive results, shows that we need more research in this area. Anorexia case series 2023, so just this year. Slightly different, more nuanced approach. Animal-based ketogenic diet puts severe anorexia nervosa into multi-year remission, a case series. Now, this is the thing with research. When you hear about case series and case studies, you think, okay, fine, they can do it for 6 months, but everybody relapses. You know, everyone who has an eating disorder is going to relapse. They'll do fine, but then something will come up and, you know, a couple months later, they'll be feeling unwell again. This is multi-year remission. So this is the first case series to document ketogenic metabolic therapy only. So no ketamine infusions here. 3 adults with very low BMI, so 10, 11, and 13. These are not weight restored. And this, if we think back to the safety and efficacy that Sasha was talking about, she said acute eating disorders, we would say right now that KMT isn't suitable. This is a study that's showing otherwise. So I'm not saying now from this, though there are good results, I'm not saying that we can now do this with people who have very low BMIs, but it's showing that for some people, you know, perhaps it may work. So these 3 adults, they were treatment resistant, so refractory to standard care. Doesn't matter what therapy they had used over the years, nothing was helping them. Remission of between 1 to 5 years to date. So it's still 2023, so it's still 1 to 5 years, but 1 to 5 years to date. They followed a high-fat animal-based ketogenic diet, and they weight restored 20 kilos each. So before you start thinking, oh my goodness, KMT, it's just going to make you gain weight, this is a very tailored, personalized ketogenic diet to bring their weight up, and they were able to weight restore 20 kilos up. Reduced anxiety, so anxiolytic ketones again, and increased well-being. Here is a snippet directly from the paper. So you can see here, anorexia is a metabolic psychiatric condition, 5 times increased risk of death, 50% rate of relapse, as Sasha mentioned. There is this idea that all foods fit. Unrestricted diet is the standard care focus. This is what a lot of people are refed onto, including Ensure that Sasha showed us earlier, versus an animal-based ketogenic diet. So an animal-based ketogenic diet is as simple as it sounds. It's removing, you know, the high fibrous vegetables and mainly focusing on meat, fish, eggs, poultry. 3 patients with that BMI, as I mentioned, at least 20 kilos of weight gain, remission lasting 1 to 5 years. Now, I hope you guys can see this. This is again straight from the paper, and these are the 3 cases. So here we can see people's before and after pictures and the weight gain that they had before and after. Things that stood out to me here. This lady, Catherine, she had vision loss and a cardiac arrest when she was 35, 36. Then she followed an animal-based ketogenic diet, and so far 2+ years, and she's doing okay. Here, Trevor had neuropathy and osteopenia, all of these things that we see with eating disorders. And then 1 year plus, he's doing okay so far. The most impressive is Amelia, because she's been doing it for the longest. So she had struggles with body image and mental health, of course. She had multiple organ prolapses treated with surgical excision. So she had a lot of surgery, not feeling her best. And then for 5 years now, she's been following an animal-based ketogenic diet. You can actually find Amelia online. You can find her on Twitter, and she shares a lot about her journey. So if you're interested, I would encourage you to go and check that out. See, maybe you can connect with her and read more about her overall process. Now, what's most exciting is there is a clinical trial coming. So I'm not sure if any of you are familiar with Dr. Guido Frank. He's from the University of San Diego. He has got some funding to carry out the first randomized control trial. I think it's randomized anyway. He is a double-boarded psychiatrist with over 100 peer-reviewed publications investigating neurobiology of eating disorders. This is what he has to say. So for several decades, it's been hypothesized that anorexia nervosa is a metabolic disorder of psychological origin. Our studies will investigate how nutritional ketosis impacts brain circuitry and behavior in anorexia nervosa and ultimately psychiatric disease. So it's going to be a 14-week trial. Now, this is great because in mental health research and ketogenic diet research, 12 weeks is what is the ideal timeline for somebody to follow a ketogenic diet to see the best effects for mental health outcomes. So 14-week trial studied in 20 individuals. Now they're going to be weight normalized with a BMI of 17.5 and above. So again, it's not acute eating disorders with very low BMI, it's weight restored, but they still have that high impairment. And they're also going to assess for the underlying genetic basis. And so if we think back to the vulnerabilities, when people have eating disorders, perhaps they are vulnerable to eating disorders. This is what people suggest. We have the phenotype, so the gene-environment interaction. Then we have the overlap with affective disorders, stress and malnutrition. It's really interesting that Dr. Guido Frank is going to be looking for that underlying genetic basis, because that might give us some more information about those people who might be vulnerable to the eating disorders, but also who may respond better to a ketogenic metabolic approach. And there you can see the clinical trial number at the bottom if you want to check it out. Okay, so if you want to throw your questions over to Sam and John in the comments on anorexia, I'm going to start talking about binge eating disorders now, but maybe throw any questions you have about anorexia there. I can get them at the end. Okay, so again, in chronological order, 2020 binge eating disorder review. So this is, again, it's only the past couple of years. Low carbohydrate ketogenic therapy as a metabolic treatment for binge eating and ultra-processed food addiction. So there is a metabolic role in the development of maladaptive eating. We know that for sure. We know that because we've seen that a lot in type 2 diabetes research, and it's coming through here in this research too. Ultra-processed foods, refined or high glycemic index carbohydrates are a possible trigger, mediating neurochemical responses similar to addiction. I don't think this will be a surprise to any of you, but 90% or more of binge foods are ultra-processed foods or Nova-4 foods. So these are foods that are manufactured by companies, wrapped up in pretty packaging, taste delicious, but are highly addictive. And for some people, they're more addictive than for others. But yeah, 90% of binge foods are ultra-processed. If I think clinically, I don't think I have seen anybody that binges on something that is not an ultra-processed food. Sasha, I don't know about you, but I haven't come across anybody whose binge foods are not ultra-processed. Carbohydrate insulin model. So this lends to the fact that the ultra-processed foods trigger abnormal blood sugar, and then we have an insulin spike, and that changes the metabolic and neurobiological signaling. So carbohydrates come in, they give you a blood glucose spike, your insulin levels go up, then everything comes crashing down again, and then you're triggered again, you want something else, and we go up and down on a roller coaster. You don't have that when you follow a ketogenic approach. Insulin is regulated, blood glucose is regulated, and you don't have these peaks and troughs. So this results in overeating, increased hunger, which is not found, as I've just mentioned, with healthy fat intake, which has fewer insulin spikes. Now, I know the word abstaining is maybe, people don't really like this term. I wish there was a better term. Maybe I should have put in a different term, but reducing or abstaining could be considered a treatment approach, at least for some people. Now, a case series 2020. 3 participants with obesity and comorbid binge eating and food addiction followed KMT for 6 to 7 months with no adverse effects. They had a reduction in binge eating episodes, food addiction symptoms, cravings, and that lack of control, which is so often seen in binge eating disorder. They also had weight loss, which is brilliant for them, and they maintained their treatment gains for 9 to 17 months after initiation, and also continued adherence to KMT. I'm looking forward, I think there is a follow-up in the works for this research. So it suggests that therapeutic carbohydrate restriction for binge eating disorder may be more effective than the alternative everything in moderation approach. So again, we're just remaining open-minded about the fact that this might be an approach for people, for some people. And if people are not getting the results they want with standard care, then why not try this approach? Okay, pilot study. A potential treatment for binge eating and food addiction symptoms in women. Now, this is an interesting one. I have a couple of questions myself about this research, but overall, it's quite positive. So at baseline, 2 cases of severe food addiction, 1 case of mild food addiction, 1 case of binge eating with severe food addiction, and 1 case of binge eating were recorded. So 5 participants altogether. They followed a low-carb ketogenic diet with protein replacement for just under 2 months. At time point 1, so at 7 weeks, 4 out of the 5 of them no longer had symptoms at all, and only 1 had mild symptoms. They then followed a low-calorie diet for another 3-4 months, and then at the end of that, none of them had any food addiction or binge eating symptoms. So even by 7 weeks, 4 out of the 5, so 80% of them didn't have any food addiction symptoms or binge eating tendencies, which we don't really see that in eating disorder research. So it just makes us think. Now moving on to bulimia nervosa and other eating disorders. There is very little research available yet, as I mentioned, on bulimia nervosa or other eating disorders. Clinically, case studies for bulimia nervosa are positive. And as I mentioned, there is some research there that's under peer review at the moment. And if you remember back to the pharmacology, bulimia nervosa does respond well to pharmacology. So we would think or hope that perhaps the results would be similar to binge eating disorder and they would respond well. Bottom line is that more research is needed across varying demographics, different cultures, different parts of the world, different genders, and with larger sample sizes, of course. But so far, if implemented correctly, and avoiding keto flu and electrolyte balance is correct, etc., it's really a low-risk approach for a potentially high-reward outcome. It might work for everyone, it might not work for everyone, it might only work for a small percentage of people. However, it's still perhaps a treatment option for people, a nutritional approach that they can try that's, it's not medication, it's not anything else. So another option there. Let's have a look at the biological mechanisms of anorexia and ketones. So on the left, I'm going to do the anorexia mechanisms, and on the right, ketones. And I've added the PMID reference number if you want to go and check out the paper. So anorexia associated with increased inflammatory cytokines. Starvation ketosis is anxiolytic and rewarding but dangerous. Now, when people who have or who live with anorexia, they do go into a state of ketosis because they are fasting and restricting their food. So they do actually experience ketones and the anxiolytic effect of ketones. However, they do that you know, they reach dangerous levels with it because their weight becomes so low and they are malnourished. So they do reach that ketotic state, but in a more dangerous way. There are disturbances in lipid signaling, malnutrition as an outcome, and fat storage because of the insulin spikes. Because if they're eating carbohydrates and they fear fat, each time they're eating the carbohydrates, they're increasing the insulin, and the insulin is a fat storing hormone. On the flip side, ketones are anti-inflammatory, excuse me, reduce or eliminate the drive for weight loss, fear of weight gain, and body image distortion in anorexic research. Ketones stabilize brain networks. They're also, as we mentioned earlier, anxiolytic, but without the starvation. So we have the ketones, but in a very safe environment, so you can get the benefits of them, but without reaching starvation. Ketones regulate lipid metabolism, and a well-formulated ketogenic diet that's nutritionally dense can be formulated with small amounts. So that helps when people who have anorexia are choosing their foods and their portions. They can get more nutrition from the smaller amounts of food. Oh, did I miss one there? Less insulin spikes and therefore less fat storage. Okay, biological mechanisms of binge eating disorder and ketones. So on the left again, if we skip over the anorexia reported there, the NOVA4 foods, so the ultra-processed foods, 70% of those with bulimia nervosa and binge eating disorder, patients, so people with those disorders were consuming the ultra-processed foods at that percentage. And as I suggested earlier, binge foods were 100% ultra-processed. More frequent and intense food cravings compared to healthy controls. They have a disturbance of satiety. They find it very difficult to feel full. They have a sense of a lack of control. So if they're out or they are able to, in secret, get their food, they will eat to excess and sometimes say, I had an out-of-body experience. I lost control. I didn't know what I was doing until I came round. There's also a phenotype involved here, as I mentioned earlier, and that's overlapping with affective disorders. Now, with KMT and ketones, the diet itself is not an ultra-processed food diet by design. There are no ultra-processed foods there, as long as you stick to real food. You could be eating fat balls, but we're not going to do that. There will be a reduction in cravings. There will be an increase in feelings of fullness and satiety. There will be a reduction in hunger and appetite. So all of these, I do have the reference links for you if you want them. But a regulation of hunger hormones, ghrelin is regulated, leptin is regulated, appetite is regulated, balanced and regulated blood sugar levels as well, so no peaks and troughs. We're not on a blood sugar roller coaster. Everything is level and calm. Hormonal regulation as well. So as Sasha was alluding to earlier or mentioned earlier, fertility, menstruation, all of these regulate. Anxiolytic. I think anxiolytic is probably the word of the evening. Anxiolytic, again, that is what we're looking for, and that's what the ketones give. In terms of binge eating disorder, the anxiolytic properties of the ketones are really important here, because when you think about the lack of control, there is research to show that people find it difficult to find a moment between an action and the reaction, or a trigger and then their response. And with the presence of ketones, the anxiolytic effect, it helps to keep the person calm. It gives them more time for decisions and therefore gives them a sense of control. So something might happen in their life. They may have a trigger or an event, but they're able to rationalize and take a moment before they respond. And that can just give them enough time to not go and search for the binge foods. And then also with ketones, research is showing now that there are improvements in affective disorder symptoms, and some good research coming through on ketogenic diets and depression, schizophrenia, schizoaffective disorder, etc. And so this can counteract the phenotype, or maybe help with the address the phenotype that's found in the small amount of those with binge eating disorder. Okay, conscious of time, so I'll roar through the next couple of slides. How could it work in practice? Well, first step, remove the ultra-processed foods if we're looking at a binge eating disorder or bulimia nervosa population. Have a look at a pre-keto approach, a low-carb trial. Don't have to jump into a ketogenic formulation here, just lower the carbohydrates. They can still eat some carbohydrates, just more whole foods. Educate around nutrition needs for the individual. This is not weight loss, weight gain, calories. This is nutrition. Individual-led food and portion selection. So particularly with the anorexic groups, asking them to select from certain food types which foods they want to eat and which foods or what portions of those foods they would like. Okay, and so as long as they're choosing from a combination of ketogenic foods to make that ratio that Sasha showed us earlier, they can choose the portions, learn about the portions, and formulate their meal. So everything is still within their control. Then move to ketogenic approach for therapeutic ketones if needed. So if people are feeling better, but maybe they haven't really reached their full potential, or you think that the ketones might help, then you can move to a more ketogenic or a higher ketogenic ratio. Using in combination with other treatments, as this is not a monotherapy, it's not a cure-all, but rather a piece of the larger puzzle. And then who could it work for in practice? So right now anyway, individuals with weight restored anorexia. Okay, I know we have the study with slightly lower BMIs, but for now, weight restored seems to be the safer option, especially if you're doing it outside the hospital. Those with anxiety, anorexic behaviors, and the voices. Individuals with BED and BN of normal or increased weight or BMI. Contraindications, non-weight restored, like I mentioned, individuals on blood glucose lowering or blood pressure lowering medications, or anything that Sasha mentioned earlier, the SGLT2 inhibitors, pregnancy, breastfeeding. When it comes to a biopsychosocial approach, that's what we're looking for, okay? And so I wish I could sit here and say, you know, we figured it out. The research says you only need to follow this specific diet and it's going to help. That's not how it goes, or that's not how it goes just yet, because we don't have enough research to state that. It really is a personalized approach. This is where dietitians, health coaches, everybody needs to be, psychologists, everybody needs to be involved here to help out. So we're thinking about the best nutritional approach. Is it removal of ultra-processed foods, or is it a ketogenic approach? How long into ketosis? What do they like? Do they have any allergies? Gut health? Who else is in their support system? Do they live alone? What cooking facilities do they have? And so on. So there are lots of things to consider here. And the bottom line is that one size doesn't fit all. But if you work with somebody closely enough, you can figure all of this out, and you can, you know, hopefully make some improvements. And then to recap, I'm not going to go through each of these, but I think we've covered each thing in depth. Some references for you. I broke it into anorexia, binge eating, and ultra-processed foods. But if you want any other references for anything that I've mentioned, please do get in touch. Here are a couple of resources. There are way more resources that we would love you to check out. But we've got Metabolic Mind here on YouTube, Dr. Chris Palmer's Brain Energy book, which I highly recommend everybody to pick up. You can get it on Audible as well, read by him as well. So it's nice to hear it read by the author and not by a robot sometimes. And then we've got Keto Med Academy, which is the company that Sasha and I have, which is focused on educating everybody about ketogenic metabolic therapy. So what next? Feedback, but I think before we get there, we're probably going to do some questions. So if you write your questions in the comment boxes, and then Sam and John can fire them at us.
Hi. Thank you very much indeed.
No worries.
Wow. I guess very challenging for eating disorder clinicians. But the thing that came into my mind all the time was, hey, look, we get pretty dire results with about 50% of our patients. We are desperate to get new treatments. So let's, as you say, keep an open mind, and let's, trial these new things and get some scientific evidence about them. Sorry, my camera doesn't seem to be on.
Yeah,
Oh, it is on. Yeah. So John's got a few questions. Do you want to ask them, John?
Yes, I was writing them because otherwise I'd forget them. But yeah, because I think it's interesting, because I guess someone with anorexia is starving themselves, therefore is catabolizing their own adipose tissue, therefore they're in a ketogenic diet, they're kind of in dietary ketosis. And I worked in addictions before eating disorders, and worked with people who were addicted to GHB, which is gamma hydroxybutyrate, and the ketone body is beta hydroxybutyrate, and they're like quite similar. And so I wondered, is like starvation or like anorexia nervosa an addiction to ketosis, and therefore every time you eat some food and you switch off the ketone body and turn on the glucose, then do you go into a withdrawal and feel anxious and irritable and seek the return to the starved state? And yeah, so I thought, like, if you were actually working with people who go into take the ketogenic diet and go into full-on ketosis, if they all of a sudden have a baked potato, do they go into a big withdrawal state from the ketosis?
Yeah, that's a really good question. I think we could probably both, I'll say something, and then Sasha, I'm sure you have something to say on that. So firstly, just when you mentioned about people, are they addicted to being in that ketotic state? There is something there. I'm not sure for how many people here have been in that state, but it is a nice feeling. It's a nice state to be in. It's very calm, zen feeling state to be in. And if you think about people who fast, or if you think about people who like monks and things who might fast for long periods of time, they talk a lot about reaching this zen state. And I think a lot of that kind of comes into it. There's this sense of calm. And so there isn't any research that I've seen that says that is what they are reaching for, that's what they are addicted to, but they would definitely feel the drop if they were to eat something, because they are in such a high level of ketosis with the anorexia population, because they are actually metabolizing their lean mass as well, unfortunately, because their adipose tissue is probably very, very low. Their ketone levels will be extremely high, and their body will not have enough insulin to pump out to regulate that. So they really are in starvation ketosis. So as soon as they have anything, it will drop them. So if you have lower levels of ketosis and you have some carbohydrates, you'll feel the drop. The higher you go in terms of ketone levels, it only takes a very small amount for you to really feel the effects. So to answer your question, if somebody is at a high level of ketones and they feel that effect, that drop, if they have a baked potato, they are going to see an onset of perhaps irritability, fatigue, gut issues, and all of that. And then also we see in the mental health population a return of some of their mental health symptoms, so negative affect and so on. Sasha, do you have anything to add to that?
Yeah, no, I think you described that really well, Erin. And I think, I suppose the desperate irony really is that a lot of people who have anorexia are desperately afraid of foods that contain fat. And so the food that they might feel safest to try to eat would be carbohydrate-based foods, which is potentially what's going to make them feel worse than if they ate something like avocados or eggs or something like that, which they generally would desperately want to avoid because they know the numbers and they think of it purely in terms of caloric density, and fat being 9 calories per gram and carbohydrates being 4 calories per gram. They play those number games so well, don't they, that it really would need to be about psychoeducation, that there's more than just those numbers to look at.
Mm-hmm. Or even sorry, go on.
I've seen very, very few people reach a very low BMI through an eating disorder who are eating fat. Like it almost seems to be far more likely to exclude fat than like sugar or carbohydrates.
Mm-hmm. Mm-hmm.
The other thing is we had with back to GHB, because one of the issues we had with people who had severe GHB addiction and were taking it every 2 hours, when they withdrew, they had extremely difficult to manage withdrawals. That people would try and manage them like alcohol withdrawal, but it didn't work, and some of them died. And I wondered if refeeding syndrome could be something like severe BHB withdrawal, because it causes lots of confusion and death, and it's not thoroughly understood, I don't think.
I think you raise a good point. We know so little about refeeding syndrome, and what we are proposing is maybe even a more cautious approach, perhaps, to even the way it is being carried out right now, because with the ketogenic approach, you're at least avoiding the insulin spikes and the blood sugar spikes. And so if anything, you're able to kind of keep those electrolytes in balance and still nourish the individual. But I think you're right. I don't think we know enough yet about refeeding syndrome. And I'm still curious about the GHB, and I'm interested about that because with ketogenic metabolic therapy, there's some really good research that shows that it can help with the withdrawals of alcohol. So I'm wondering how with the GHB, how then how it's different. How if the ketones work for the withdrawal of alcohol, but then the GHB doesn't. I don't know.
GHB would work. They're all GABAergic. They all increase the GABA activity in the brain.
Yeah.
GHB, GHB, alcohol, diazepam.
Yeah.
Because with the microbiome, so like a lot of people with anorexia have less variation in their microbiome, and especially less butyrate producing species. Like we did one of the UCL studies that we did, just a systematic review, showed like less roseburia. And is that the butyrate, I guess, it seems to be associated with feeling calm, and people with eating disorders or anorexia nervosa have less of it. So I wondered what the interplay was there. Anyway, that's enough for me. Sam, do you want to read out some of the other questions?
Sure. So Hannah says, how would you be able to test whether the sense of calm is physiological, or whether it's because an eating disorder rule, for example, is because it's an eating disorder rule. For example, sugar is scarier than fat. So for somebody who found sugar is scarier than fats, then eating fats might be, they might be able to be more compliant with it and find it more acceptable.
That's a great one. I think with all of these things, as a biopsychosocial approach, it's difficult to unpick everything. What we do know is that research has shown that ketones within a certain level, between 0.8 up to 1.5, that level of BHB in your blood gives those anxiolytic effects for most people. Sometimes maybe people might have to be a little bit higher, a little bit lower, but generally speaking, that range. So we know that if you're in that range, you're getting those anxiolytic effects. However, we don't know if it's also because you have a food rule and you feel comfortable with that. Sasha, do you have anything to add? Because, perhaps you've been working with people with eating disorders a little bit longer than I have in this area.
Well, I think it's easy to test ketones in the blood. That's an objective measure, and mood and anxiety levels is a little bit more subjective. And I think the blend of the two gives us the best data. So, sorry. I guess it would be a really interesting study, wouldn't it, to look at specifically in anorexia nervosa and their experience of anxiety, and compare that to their to the monitoring of their blood ketone levels. It would be super interesting. And I guess the answer is that we don't know yet. We can make assumptions, but I think that further information is required.
I think also the one thing, because sometimes with this research, and I'm probably guilty of it because I'm a researcher and a clinician, we like to get in the weeds about what to test and optimal levels of this and that, when actually, once we implement ketogenic metabolic therapy, as long as the person is improving, and whatever that means for them, that is what we are looking for. So if it's that it's because of the ketone levels, brilliant. If it's because they have this rule that they then feel calmer about, fine. If they feel calm with a certain rule and they're still able to, eat a well-formulated, nutritionally complete diet and be healthy or have the return of their health, then that's what we're looking for.
Okay, thank you. It's a question from Ruth Dawson. How long do you think you would need to trial a ketogenic diet to see if it was helpful? Sounds like not very long.
Well, I mean, we expect people get into ketosis within a few days. The keto flu sort of peaks about day 3, day 4, and the adaptation continues after that. So for mental health, we like people to give it 12 weeks. But we generally start to see improvements in the first couple of weeks that they're in ketosis.
Yeah, linked to that, Hannah said, would the ketogenic approach be a short-term approach or something to consider longer term? So, I mean, people kind of being expected to carry on eating like this for the rest of their lives, or?
Well, this is always the question, isn't it? Is do you do it indefinitely? And so we know with epilepsy that people who use ketogenic diets to prevent seizures, if they eat a banana, the seizures come back, and often with a vengeance. And so, but what's happening is that as you are in ketosis for longer, your brain and body cells are producing more mitochondria, and they're getting rid of the old senescent mitochondria at a better rate. And so with time, you have this increased adaptation. And as long as the symptoms don't come back when you come out of ketosis, some people can cycle out of it. And there's certain times, for women, we know from clinical practice, not a lot of research, but it's the late luteal phase, so the week before menstruation, is more difficult to start ketosis and to maintain it because of the shifts in hormones. So I think that it really does need to be a personalized approach. And with anorexia, because there's not a lot of research yet, we don't know specifically if it's needed forever. We know with some mental health conditions that their ketone levels can be lower and they maintain remission. So they can, liberalize their diet a little bit.
I think also to add to that, some people might say, okay, this ketogenic metabolic therapy, this diet, this is so restrictive. Does this person have to do this forever? What I have heard and seen clinically is that people who have moved to this ketogenic metabolic therapy and this approach and are doing well and would say that they're in remission now from their eating disorder, say that they have found freedom in that. So to them, they're nutritionally complete and weight restored. They don't want to change anything now because they're feeling good hormonally, metabolically, mentally. And so to them, they're not going to, they have a sense of control, in what they're doing and what they're eating, and their health markers are the best they've ever been. So they don't want to go and mess that up and, try to have something else, more carbohydrate laden.
Absolutely.
that links into another point from Hannah, which was she was worrying that the keto approach maintains food rules, which could ultimately lead to relapse, whereas All Foods Fit aims to get rid of food rules altogether, in this sense, reducing the risk for relapse. And I guess I think I would say to that is that 50% of our patients can't do that, can they? So why not look at something else?
What have you got to lose,
Yeah.
kind of thing.
Yeah.
Yeah.
And
And
some
you know, the All Food Fits, I think, is a noble cause with noble intent. But we have to remember the power of the food industry. And All Foods Fit, I think who benefits from that is the producers of ultra-processed food, who want us all to feel that these foods should or can be a part of everyday diets. And I suppose we could all argue that 100 years ago, they were not a part of anybody's diet. And when you look at the dramatic increases in chronic physical and mental health conditions since the advent of ultra-processed foods, it seems an argument that is difficult to continue to support. Now, to avoid overwhelming food rules that are not in a person's physical and mental health interests, that make people unwell, these food rules that, you know, don't support us, that definitely needs to be avoided. But if somebody has a food rule that keeps them well, then, you know, perhaps that's something that we should be supporting.
Yeah. I've got to put my halloumi in, but I want to ask a question and then I'll listen to the answer. This is all very well. What do we know about the very long-term effects, if anything, of a prolonged ketogenic diet? I'm talking about, do we know anything beyond a year, 5 years, 10 years? I had a quick look earlier and there's 2 or 3 papers, but it doesn't look like there's an awful lot of knowledge out there yet. And I'm going away, but I'm still listening.
Yeah. So in terms of for eating disorders specifically, the research is still new. However, the diet composition the diet compositions that are used in ketogenic metabolic therapy are the ones that we've been using for treatment-resistant epilepsy as far back as 1920, 1921. And even before that, you know, there were other I suppose if we think about intermittent fasting, etc., ways of putting people into a state of ketosis naturally, that would have been used even prior to that. So the ketogenic diet actually has the most research out of any diet ever, more than the Mediterranean diet, more than a vegetarian diet, more than the standard Western diet. It has the most research, and specifically for medical causes, as far back as the 1920s. And also the research is in really sick individuals. It's not like the research is just done in healthy people and they had good results. No, the research is in people who are not getting better. They are extremely unwell, and yet the ketones and other mechanisms of the diet have been able to help that individual improve in their physical and mental health. So
as you know, I was just thinking about hunter-gatherers.
Yeah.
And presumably they'd have been eating high meat or relatively high meat and berries and, you know, fruits that you could pick and stuff, and relatively low carbohydrate, one would imagine. So perhaps that's where we were built originally.
And if you think about when we eat as well, so I know we're not talking much about fasting here today, but if you think about back then, even 50, 60 years ago, we would have had a couple meals in the day, dinner would have been at 6, wouldn't have had anything through until maybe 8 or 9 the following morning. Often that's long enough for people to be producing ketones, even if they're on a standard diet. And then also to back that up, when babies are born, babies are born in a state of nutritional ketosis, and the mother's breast milk is full of lots of fat and MCTs and etc. So the baby can remain in a ketotic state, you know, and get all the nourishment that it needs to grow its brain and everything else. So yeah, lots of bits across evolution. Do you have anything to add, Sasha?
No, just exactly what you both have said, Sam and Erin, that you know, for most of human history, we were probably in ketosis most of the time, and every once in a while you'd fall upon a pot of honey or a patch of berries and and come out of ketosis. So it is a relatively natural state of being.
Mm-hmm.
Got another question from Sarah Fuller. What's the impact of keto on bone health? Poor bone health is very common in restrictive eating disorders. Could keto help or hinder? Well, I guess partly if it improves menstrual status, it's likely to help rather than hinder, isn't it?
Yeah. So when periods can become regular again, then that has a positive effect on bone health. But we definitely consider that. So certainly people need to have adequate levels of vitamin D. We test levels at the start and at periods throughout people's ketogenic journey, and some people will need calcium as well, depending on, you know, the formulation of their diet. But certainly it's something to consider as well, as it is for all of us. I mean, there's national guidance. We all need vitamin D.
Yeah. No, I need more sunlight. That's what we need.
Yeah.
John, do you want to finish off on your questions?
Yeah. Just measuring ketosis, because you can do like a blood fingerprint, can't you, or breath or urine. But is there any way of like knowing how, like in the same way that you can do HbA1c for like glucose level, can you do anything like that for ketones?
On like a 3-month average, you mean?
Yeah, or do you find that they have very low HbA1cs because they're not ingesting any carbohydrate?
Yeah, so the HbA1c, yeah, it does regulate. It does come straight down into the normal range, and usually quite quickly. Just within a couple of weeks, it will come down to the normal range.
But if they've been in ketosis for 6 months and you did that HbA1c, would it be very low?
Yeah.
Yeah, it would be in the normal range. It doesn't go very low. So it's not that the ketones will go high and the glucose will just continue down to 2 or 3. It will just come down to about 4.5 millimole and then just stay there pretty consistently. So that's what you see with the HbA1c. Does that answer your question?
Yeah. So I'm just thinking about if you saw a patient in outpatients and they said they've been eating well and you did their HbA1c, would that be a good way of seeing that they haven't been? But
yeah, we you see a kind of seesaw effect between ketones and blood sugars, and so when we see patients, we have them testing both ketones and ideally blood sugars as well. And we have an online platform, so it's very easy to remotely monitor. It's one of the great things about KMT is that you can measure compliance because you can see what their ketone levels are. But yeah, unfortunately, there's no equivalent of A1Cs for ketones. We can't look at what their average ketones were in the blood, except by going back and looking at the data and how that averages when they measure their ketones at specific points. But generally speaking, yeah, the A1Cs will go down.
They do that with finger pricks.
Yes.
Yeah.
And is Abbott developing a like Freestyle Libre but for ketones?
Yeah, it was meant to come out in June this year, and I've been waiting for it. There was a Chinese company called CSIBIO, and I trialed their ketone monitor for a while, but it didn't correlate well with the Keto Mojo, which is the gold standard blood ketone meter. So it's not there yet, but I'm really looking forward to the Abbott one because they've got a really good track record with their Freestyle Libre. And I think the continuous ketone monitors will be a game changer, definitely.
Excellent. Were there any other questions, some, I don't think there were. Hannah said, really enjoying this. Thanks for answering all my questions. Makes me want to experiment myself. No better research than to really feel, experience it. But it seems quite a challenge coming from a vegan lifestyle. Thank you for tonight. Interesting. And I tried it for a bit. I found it almost impossible, especially in the service station. I ended up eating a lot of prosciutto. That was all I could eat. Drove my wife mad. Anyway.
Cheese stick.
Yeah. Excellent. So thank you so much for a very interesting webinar. So we're going to upload it to YouTube as well, but the conversation can continue on BrEDS. So thank you very much, everybody, and good night. Enjoy your evening.
Thank you. Thank you very much.
Thank you. Bye.
So I've just ended the live. So thanks. That was awesome. That was very interesting for me. So I think, like, in terms of numbers, I think there was about 20 people kind of coming in and out, like with an average of about 12. But yeah, there was a lot of people that are interested in it. I think some of them found it difficult to join at the start, which sometimes happens. But yeah, you see, it will notch up views over the next week, and then we don't normally put them on YouTube. So it'd be interesting to see how it does there.
Yeah, let us know the numbers. That would be super to have the follow-up. Yeah,
it was really interesting. Are you going? Oops, my battery's going. Are you kind of going to be putting in abstracts for conferences and stuff as we go forward?
Yeah,
I think.
Like I would like to do some research in this for sure with eating disorders. Like with the UCL master students, we have students ready to go with £1,000 budget to do various projects. But yeah, especially when those ketone monitors come out, because like, you know, when people have hyperemesis gravidarum and they go into ketosis, don't they? And is that just because they're vomiting so much, or because they aren't ingesting?
They've often really struggled to eat, don't they? So their actual intake is so low.
Yeah, because
there'll be electrolyte imbalances as well, won't there, with all the vomiting?
Yeah, because I just wondered if people with bulimia who are vomiting a lot, is that doing something with ketones? But anyway, I should let you go.
Might be. We should definitely stay in touch though, because if you have students that are interested in doing, research in this area, then we could definitely come up with something.
You'll get to beam. You'll see them on Wednesday if you're beaming in for that.
Of course we will. Yeah, that'll be fantastic.
Yeah, so I look forward to that. Anyway, I'll sign off. Good night, everyone. Thank you so much.
Okay, thank you so much, guys.
Thank you.
Thank you.
Bye.
Take care. Bye.
Bye.